Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Post-exposure prophylaxis. Before going in detail about post-exposure prophylaxis, we will see what is meant by exposure. Exposure refers to a situation where an individual comes into contact with potentially infectious material. Example, blood, bodily fluids of a HIV positive patient. Exposure may place an healthcare personnel at risk of blood-borne infections. National AIDS Control Program divides this exposure into two types and provides PEP services only to occupational exposures. Examples, needle stick injuries and splash of blood or bodily fluids onto mucosa or broken skin. These are all occupational exposures occurring during job-related activities. Coming to non-occupational exposures, where PEP services are not provided under NACP except for sexual assault. Victims of sexual assault are provided with PEP, even though they are categorized under non-occupational exposure, that is, exposures occurring outside the job. Examples, unprotected sexual intercourse, where the risk is 0.1 to 10%. Sharing needles among drug abusers, where the risk is 0.67%. And sexual assault. Coming to risk with different body fluids. At-risk fluids are blood. Risk of transmission of HIV through blood transmission is more than 98%. Highest risk is with blood transfusion. And vaginal secretions, fluids like amniotic fluid. The risk of perinatal transmission is about 20 to 40%. This risk will reduce if mother is treated with ART. Pleural fluid, peritoneal fluid, pericardial fluid, cerebrospinal and synovial fluids. Remember, like this, at-risk fluid are bodily fluids present inside. Not at-risk fluids are bodily fluids which is secreted out, like tears, sputum, sweat, urine, feces and vomitus, and saliva. These are all fluids not at risk unless they are contaminated with visible blood. Coming to our main topic of discussion, post-exposure prophylaxis, which refers to a comprehensive management instituted to minimize the risk of infection following potential exposure to blood-borne pathogens like HIV, which includes first aid, not only just antiretroviral drugs, it includes first aid till follow-up support, maintaining confidentiality. We will see now one by one. First aid, that is management of the exposed site. For skin, wash the wound and the surrounding areas with soap and water. Do not use scrub, alcohol, antiseptic, bleach, betadine and chlorine. For eyes, irrigate the exposed eye immediately with water or normal saline. How we will do it? We will sit on a chair and we will tilt our head back and we will ask our friend or colleague to pour normal saline or water onto the exposed eye. If we are wearing contact lenses, no need to remove contact lenses while irrigating, as they form a protective barrier over the eye and protect while irrigating. Do not use soap or disinfectants on eye and mouth. For mouth, spit the fluid out immediately. Rinse thoroughly with water or normal saline. Repeat this process several times without swallowing. Coming to second step, which is counseling for an informed consent. Why here we have to take consent? Before doing HIV test, we have to take consent from any individual. Without their consent, we can't proceed to test. That's why on investigating paper, it will be written VCTC, Voluntary Counseling and Testing Center, which means first step in HIV testing is counseling. Second step is the actual HIV testing. Exposed person should receive appropriate information that he or she should practice safe sex using barrier method condoms and avoid pregnancy, giving breastfeeding and blood donation till what time? Both baseline and 3 months HIV test is negative. Adherence to drugs, we have to counsel the importance of adherence to drugs and about adverse reactions. Psychological support to relieve anxiety. Coming to step number 3, risk assessment. Exposure code EC. For an intact skin, no PEP is required. For exposure onto mucosa or where skin integrity is compromised. And for percutaneous exposures, it is categorized into exposure code 1, which is mild exposure, exposure code 2, which is moderate exposure, exposure code 3, which is severe exposure. How it is categorized, we will see. For mucosa and skin integrity compromised, based on volume and time. If volume is small and duration is for a short duration, it is categorized under exposure code 1, that is mild exposure. If volume is large and duration is also large, then it is categorized under exposure code 2. For percutaneous exposures like needle stick injuries, superficial cuts, based on severity. If it is severe, which means more hollow bore needle and deep injury, that is categorized under severe exposure, which is exposure code 3. If it is less severe, where we will call it as less severe? If the needle is solid and the cut is very superficial scratch, then it is categorized under exposure code 2, which is moderate. For exposed person, 3 categories are there: mild exposure, moderate exposure and severe exposure. EC code 1, 2, 3 and respectively. Coming to source. If source is available, we have to counsel them and take their blood for HIV testing. If it is negative, no PEP is required. If it is positive, we will categorize them into low risk and high risk. Remember like this: for low risk, low titers of viral load, asymptomatic with high CD4 count. For high risk, high titers of viral load with low CD4 count, symptomatic or advanced disease. Low risk is source code 1, high risk is source code 2. What if the status is unknown? It is categorized as source code unknown. Coming to step number 4. Provision of antiretroviral drugs based on exposure code and source code combination. Exposure code 1 means mild exposure. Source code 1 means low risk, means low titers of viral load. PEP is not warranted. remaining all combinations of source code and exposure codes, PEP is given antiretroviral drugs for 28 days, means 4 weeks. If source code is unknown, consider PEP drugs if HIV prevalence is high in that area. When PEP should be started? Preferably within 72 hours, ideally within 2 hours, as it has shown its greatest effect if begun within 2 hours. If more than 72 hours has passed, can PEP be given? Yes, it can be still given after counseling about its effectiveness. Coming to drugs. If for an adult weighing more than 30 kg, tenofovir 300 mg, lamivudine 300 mg and dolutegravir 50 mg. Fixed drug combination. All these 3 drugs will come in a single tablet, 1 pill per day for 4 weeks. Alternative regimen, tenofovir 300 mg, lamivudine 300 mg in place of dolutegravir, efavirenz 600 mg, double the dose of tenofovir and lamivudine 300 mg. For children more than 6 years and weighing more than 20 kg, zidovudine, lamivudine and dolutegravir based on their weight band. If hemoglobin is less than 9, in place of zidovudine, abacavir is given. For children less than 6 years and less than 20 kg, zidovudine, lamivudine, either lopinavir or ritonavir based on weight band. Same if hemoglobin is less, in place of zidovudine, abacavir will be given. Along with antiretroviral drugs, for every accidental exposure to blood, we have to give hepatitis B vaccination. If never vaccinated, we have to give full course, that is 3 doses at 0 day, 1st month and 6th month. If fully vaccinated, then also we will give a booster dose. Only if anti-HBs antibodies are more than 10 international units per ml, there is no need to give any vaccination of hepatitis B. But everywhere anti-HBs antibody tests won't be available to do, and there is no need to wait for this test to come. We can give a booster dose. Coming to laboratory investigations, both for exposed and source. For source, for what purpose we will do? To categorize either low risk or high risk and to assess the risk. Here for exposed person, we will do baseline HIV, hepatitis B and hepatitis C testing. If HIV test is positive, then he has already infected. No need for PEP drugs. We have to continue antiretroviral drugs for lifelong. If it is negative, to minimize the risk of infection, we have to give PEP, antiretroviral drugs, for a period of 28 days, that is 4 weeks. Then we will do again testing at 6 weeks, then double the time, 12 weeks, then again double the time, 24 weeks, that is 1.5 months, 3 months and 6 months. Why we are doing this many times? One test is enough? No, because of PEP drugs, the time for seroconversion may prolong. So we will wait for some time to get seroconversion and then again we will check before assuring the patient as HIV free. If patient is being started on drugs, we will do LFT, RFT, CBC and blood sugars. Coming to last step, follow-up support. Monitor for signs of seroconversion and side effects of the drugs weekly with necessary laboratory investigations, psychological support and mental health counseling. What are the signs of seroconversion? Acute fever, generalized lymphadenopathy, non-specific flu-like symptoms, cutaneous eruptions, ulcers over mouth and genitalia. Here, seroconversion means it will take some time for the virus to increase its load. Then our body will produce antibodies against it and cytokines will be released, leading to all these signs. How much time it will take for antibodies to produce against the virus? 3 to 6 weeks. So our HIV tests will become positive only after this seroconversion. It is called window period, where HIV test will become negative. So for a source, if HIV test is negative, that doesn't mean no PRP is required. Maybe he will be on window period. Side effects of drug will start immediately after taking the drug, not like seroconversion. In contrast to seroconversion, which will take 3 to 6 weeks. Remember my channel name, The Average Derma Doc. Don't forget to subscribe and share my channel. Thank you. Hasta la vista. До свидания.